Good evening, everyone. Thank you very much for sparing your precious time to tune into a very special panel discussion on a pressing human rights issue. My name is Hussein and I'll be your host for tonight. By way of introduction, I'm a lawyer who specialises in migration, civil and company law. Part and parcel of my focus on Australian migration law, I endeavour to advocate for the rights of the vulnerable, in particular for refugees across the globe. To pay it back, I currently volunteer as a human rights lawyer with the Advocates for Dignity, which is a human rights organisation that aims to raise awareness of human rights violations within Australia and around the world. We do this by engaging with various communities and organisations, law and policy makers, media experts, academics and researchers. We organise panel discussions similar to tonight, provide migration law assistance to refugees globally, publish a magazine, organise media stories, and many more. Before we commence tonight's proceedings, I would like to acknowledge the traditional custodians on the land from which we gather, albeit virtually. I join tonight's panel from the land of Boonwurrung and Wurundjeri people of the Kulin Nation and pay my respects to their elders, past, present, and emerging. I'd like to also add, which I recall Julian Birdside QC passionately suggesting at one of our annual iftar dinners, that the lands we stand on was and will always rightfully be Aboriginal land. We hope to make this panel as interactive as possible for our viewers tonight. We encourage you to submit your questions via the available YouTube chat throughout tonight. In the final segment of the Peace Summit, there will be a Q&A where some questions from the audience will be asked and answered. This year, to celebrate the International Day of Peace, we've organised the Peace Summit. Each year, the International Day of Peace is observed around the world. The UN General Assembly has declared this as a day devoted to strengthening the ideals of peace through observing 24 hours of non-violence and ceasefire. In 2021, as we heal from the effects of the pandemic, we consider ways of recovering collectively as people and reimagining a more equitable, sustainable, and inclusive world. In the spirit of the vision, the theme for this year is recovering better for an equitable and sustainable world. The vaccine is our way out of this pandemic, and ensuring vaccine equity across the globe is critical. Due to existing economic and political imbalances between nations, less resourced countries are struggling to keep up in the global vaccine race. Access to life-saving vaccinations and treatments is particularly challenging for people caught in conflict. The International Day of Peace is raising awareness of this issue, which affects a large portion of the global population. As we reimagine our presence on this planet and recover from the pandemic, the International Day of Peace also encourages us to make peace with nature and work collectively towards a more sustainable global economy to produce jobs, reduce emissions, and build resilience to climate impacts. The Peace Summit is an opportunity to raise awareness around vaccine inequity, including access to vaccines, but also our relationship with public health advice and the public health system as the determinants of whether we get the vaccine or not. Please also note that at the end of tonight's event, we will provide a very short and concise feedback form, which will be available via our YouTube chat box, as well as have a QR code broadcasted on your screen, so that our viewers provide their valuable feedback on tonight's panel discussion. Do not let it cross your mind that your feedback is invaluable and hence shy away from clicking the survey link. Please allow me to introduce our amazing panelists for tonight. Our first panelist for tonight is Professor Barbara McPake. Barbara is a health economist specialising in health policy and systems research. Her research focuses on the application of economic theories and methods to the understanding of issues in health system strengthening in low and middle income countries. Currently, she's the director of the Nossal Institute for Global Health, University of Melbourne. Professor Barbara's keynote address will be featured in the second segment of tonight's event, as she is unfortunately unable to make it tonight. In her keynote address, she delves into the history of vaccines and paints a picture of where we are at with the global race for the COVID-19 vaccines. Our second panelist for tonight is Dr. Tori Oliver. Tori holds a Bachelor of Medicinal Chemistry and a PhD in Pharmaceutical Science, and is a Senior Technical Advisor in the Maternal, Sexual and Reproductive Health Unit at the Nossal Institute for Global Health. Throughout her professional career, Tori has developed and maintained a keen interest in understanding and addressing inequities in access to essential medicines, which has extended into vaccine equity in the context of the COVID-19 pandemic. It is this same topic on which Tori develops and delivers educational content for undergraduate and master's students at the University of Melbourne. Baneen, I'd like to also introduce our third panelist for tonight, Baneen Alrubayi. Baneen is a young Muslim female, daughter of refugees, coming from a low-income family, attending a public school and being born and raised in rural Australia. She has been exposed to various forms of inequalities. This has allowed her to understand the influence of social determinants of health on a person's well-being. Baneen moved to Sydney in 2019 to pursue a career in medicine, and as a current third-year medical student on full-time placement in Greater Western Sydney. She was also awarded the 2019 Young Australian of the Year for the Moira Shire and is currently AMSA Global Health's Co-National Coordinator and the National Rural Health Student Network's Publications and Sponsorship Officer. I'd like to express my warmest gratitude and thanks to all our panelists for attending tonight's proceedings. As a brief outline of tonight's panel, we will have a panel discussion for approximately 20 minutes with Dr. Tori Oliver and Baneen Alrubayi. Then we will have our keynote address, which will go for approximately 20 minutes thereafter with Professor Barbara McPake. And then finally, we will have our Q&A session for approximately another 20 minutes thereafter. Without further ado, we will commence the first segment where I will ask questions to the panel on the global race for the vaccines. We will hear responses from both a research perspective on the global race for the vaccines and from a more local community perspective on possible factors influencing our decision to take the vaccine. Both these perspectives, in a way, speak to what accessibility to the vaccine looks like, whether it be the real presence of the vaccines or our social conditions determining our relationship with public health information and therefore the vaccine. Put in your questions in the chat box. And again, I welcome the panelists. Welcome, Dr. Tori and Baneen.
Thanks, Gunnar. It's great to be here.
Thank you for inviting us to come and talk to you guys.
No problems at all. I will start with asking a question to Tori. Tori, 21 different COVID-19 vaccines are now being rolled out in countries worldwide with at least 6 billion doses of the vaccines approximately administered around the world. Broadly speaking, what are your views on the current global race for the COVID-19 vaccine?
Yeah, thanks, Gunnar. And I think the term race is such an apt way of describing what has gone on with the COVID-19 vaccines. And that really actually began as a medical research race, almost as soon as the first cases of COVID-19 were reported as coming out of Wuhan in China. The pharmaceutical industry was racing to prepare and develop vaccines against the virus. This was something that we knew would have happened for quite some time. We knew that this was coming. But then the race that's actually been that's a race that's actually been something quite of a success story. So the speed at which we were able to develop incredibly safe and effective vaccines has been actually quite a scientific breakthrough. But then the second race that was playing out really in parallel and has now taken center stage, and that's the race to actually secure access to those vaccines. And this is where we've seen, as you mentioned in your introduction, some really gross inequities across the globe. So what's happened is that many high-income countries have really been able to leverage their immense resources in two ways. They've invested money directly into the drug development process to support the pharmaceutical industry in developing these vaccines. And they've also committed in advance to purchase millions and millions of doses. And through these very large investments, what they've done is essentially put themselves at the front of the queue or at the front of this race. And actually, what's happened is most of these high-income countries have secured far in excess of the number of doses they actually need. So Canada, for example, has been a notable example of this. They've made deals to purchase enough vaccines to immunize their population more than 5 times over. And yet at the same time, it's going to take years before enough vaccines can be manufactured to meet the global demand. We've never before seen this type of scenario where every person in the world needs a dose of a vaccine. And so the manufacturers simply aren't able yet to keep up to supply that need. So when these countries are placing themselves at the front of the queue and reserving more doses than what they actually need, they're doing so directly at the expense of lower resourced and lower income countries who don't have that same purchasing power or that same ability to secure doses of vaccines for themselves. And so that's where we're seeing this race play out and really leading to some of these really incredible inequities in access to the COVID-19 vaccines, where, of course, it's the most vulnerable and the most currently disadvantaged populations who are unfortunately losing this race as it stands.
Yeah, you're exactly right, Tori. I had a chance to listen to a segment from ABC News. There was Mark Cubitt from the Australian International Development Network, and he drew a parallel to describe the 10 rich countries like Australia, similar to a situation as driving a car on a cold night on St Kilda Road with thick clothing and the heater on. Then you have a homeless man who's about to buy a sweater to keep himself warm for $1. You jump out of the car and you overbid the homeless man. You pay $7 for the sweater and jump back in the car. So it's really an oversupply of vaccines when there's others that need it, and you're just taking the whole share. Thank you for your response. I'd like to now ask Baneen a question, if that is okay. Baneen, you have a unique perspective to offer in that you can speak to your experience as a member of a culturally and linguistically diverse community. You're also a medical student and a seasoned advocate and volunteer in the field of public health. We talk about vaccine inequity in terms of physical availability, just as Tori did, and accessibility of the vaccine. However, this remains a narrow approach when considering the issues around accessing, understanding, and trusting public health advice around the vaccine. This then leads us to consider the social determinants of health. From your personal research and experience, what are social determinants of health?
Yeah, sure thing. So as Dr. Tori was saying before, so one aspect to consider is the physical availability of the vaccine, but something else that we always have to also think about is the accessibility of the vaccine. And that's where social determinants of health comes in and plays a larger role. And so the World Health Organization defines social determinants of health as the non-medical factors that influence health outcomes. So basically, if you think about it, it's basically the conditions that people are born in, they grow in, they work in, they live, and then they age. So it's also the wider set of forces and systems that shape the conditions of daily life. So it's things like the social norms, the social policies, political systems. And I think an easier way to understand social determinants of health is probably to go through an example. So if you guys could just take a second to imagine that you're a 12-year-old, let's say boy or girl, and you're living in a rural area. And so this is a very small country town, about, let's say, 5,000 people, and there are no cheap local supermarkets. There's just a Woolworths. And we all know that healthy food is more expensive. Even in Woolworths, when you go in, healthy food is a lot more expensive than junk food. Not only that, but in this rural area, there are many fast food restaurants. So there's a Macca's, there's a KFC, there's a Hungry Jack's. And we also all know that fast food restaurants are very cheap. You can get your food there very quickly. They're very convenient, and you can get a nice filling meal. So not only that, but let's also imagine that you come from a big family. So you have 5 other siblings. Your parents both don't work, so they're unemployed and there's job insecurity. And with that, there also comes poor health literacy. And your parents may also, because they don't have a job, they're probably living off Centrelink. So there's financial insecurity as well. So if you imagine that you're that 12-year-old kid, there is a very high chance that you may not be having a healthy diet. But the thing is here that we can't really blame you, or we can't blame your family or your parents for this, because the reason for that is ultimately all of these social determinants of health, and they're all impacting this final outcome of you not having a healthy diet. And then this will escalate as you get older and older, and you'll be at a higher risk of more health issues and health diseases like obesity, like diabetes, like cardiovascular disease. And I just want to also highlight, like, this example here is quite a simplified example, and there's ultimately so many other factors that play into a person's overall health. And if we try to, I guess, focus a little bit more on our culturally and linguistically diverse population, things like social integration, things like community engagement, things like housing, education, accessibility to linguistically and culturally appropriate and respectful care, all of this impacts that directly impact our culturally and linguistically diverse population. And so basically, when we say social determinants of health, that's what we're talking about. We're talking about all of these non-medical factors that ultimately directly impact a person's health. And it's also important here to consider, so at the start I told you to imagine you were a 12-year-old kid. Can you also consider that this kid grows and then they'll have their own family? Do you think these social determinants of health will continue into their family, into their new family? Will they have these similar social determinants of health? And usually that is the case, because the cycles that we're born into, we perpetuate into our kids and into our families. So overall, after all talking, when we consider social determinants of health, it's really important to understand that they influence health inequities a lot, and they are basically the unfair and unavoidable differences in health status that we see within and between countries. And it's also when you look at the data, I was looking at the World Health Organization's page on social determinants of health, and they said about 30 to 55% of health outcomes are influenced by social determinants of health. So social determinants of health are they play a very large role in a person's overall health in the future. So yeah, I hope that answers the question.
Yes, I'll leave that to the viewers to give us some feedback if it has, but I was quite satisfied with the answer. Thank you very much. I think that ties in well with the next question I was going to ask Dr. Tori. Early this year, we saw the UN Secretary General Antonio Guterres describing the goal of providing vaccines to all as the biggest moral test before the global community, underlining that everyone everywhere must be included. Yet progress on vaccinations has been wildly uneven and unfair, as you were pointing out earlier. Early this month, World Health Organization Director General Tedros said on September 14 that most countries with under 2% vaccination coverage are in Africa, where less than 3.5% of the continent's eligible population is fully inoculated against COVID. Africa will likely miss the World Health Organization target of a 10% vaccination rate by the end of the year. In your views, how can global institutions such as the World Health Organization or United Nations Development Program contribute to vaccinating low and middle-income countries who are struggling to keep up with the much wealthier countries in vaccinating their populations?
Yeah, it's a really great question, Gunnar, and I guess it's the simple answer is they have a really huge part to play, and their role is really critical. And they have already been working towards achieving greater equity of access to these type of vaccines. In large part, a lot of this has come through establishing an initiative known as Kovacs, which many will have heard of. And this is a multilateral initiative designed to enable more equitable access to not only vaccines, but a variety of other tools and technologies designed to combat the COVID-19 pandemic. And essentially how Kovacs works is it pools the purchasing power of several different countries and institutions and organizations. So, I described the situation before where a large high-income country can harness their own purchasing power. Well, Kovacs sort of aims to do the same by pooling all those powers, and it then can make deals with the pharmaceutical industry so it can provide and secure enough doses. And Kovacs is really aiming to secure enough doses to vaccinate between 20 to 30% of the population in low and middle income countries who otherwise wouldn't have the resources or the same purchasing power to secure enough doses for their population. But you can still see that between that 30 to 30% there's still a gap. There are still millions and billions of people in these settings that will miss out on the doses of vaccines that they need. And then, we've all spoken already today about that it's not just ensuring the availability, the physical availability of these doses. Accessibility of the doses is really what it takes. It's not just about having vaccines, you need vaccination, and they're not necessarily the same thing. So there's a whole raft of systems and social determinants, like Baneen really aptly spoke to, that influence the degree to which a vaccine can make it from the tarmac of an airport in a given country into the arm of those who need it. So you need functional supply chains. You need a strong health workforce that's there and ready to deliver the vaccine. Some of the most important barriers that we're seeing play out at the moment are the education and the information campaigns that are needed to promote acceptance and generate demand and address what we're seeing a lot as this kind of misinformation and vaccine hesitancy. And so all of these things are limited in resource poor settings. So what we're seeing is it's not just availability that's the barrier, and we're seeing even in some countries that have had doses delivered to them, those doses are going to waste because they're not able to get out to those who need it. So I guess in short, these UN agencies and a lot of these international collaborations need to be working hard, and they are to some degree, but there needs to be more progress towards not just securing availability of doses, but building up the systems needed to actually deliver those doses into the arms of the people that need the vaccinations.
Yeah, so basically it's not just about the vaccine supplies, it's about the infrastructure that goes around it and the people that is needed to administer it.
Absolutely, yeah.
Excellent. Thank you very much for your contributions till now. I think it's time to start the second segment where we will broadcast the keynote address from Professor Barbara. So just bear with me as I share the presentation.
To be with you here this evening, even if only by pre-recording and remotely. But I really look forward to hearing your feedback to the ideas that I'm going to be talking about today in due course. I'm talking today about the issues of the global distribution of COVID-19 vaccines. But first of all, I want to just talk about the general background to how vaccines are distributed globally and the developments that have created the infrastructure that we now have from which to think about COVID-19 vaccination. So just starting with 1974 was when WHO first introduced the expanded program on immunization. And at that time, less than 5% of the world's children were immunized against what are now known as the basic, had received the basic vaccines against diphtheria, tetanus, whooping cough, polio, measles, and TB. In 1984, the Universal Childhood Immunization Initiative was launched with the aim of achieving universal child immunization by 1990. And in 1990, Unicef declared that duly achieved. 80% of the world's children under 13 months were now covered by vaccines. There were some issues around that. A large number of countries hadn't reached 80%, and whether this really constituted universal coverage was contested. But clearly that was a vast advancement in a mere 10 years between 1974 and 1984. However, by 1990, there was a bit of donor fatigue around vaccination. There was a feeling that vaccine programs needed to be more sustainable and less dependent on global finance. And for that reason, UNICEF launched the Vaccine Independence Initiative, which was aimed at increasing financial sustainability, and also the Children's Vaccine Initiative, which was aiming at introducing new, improved and integrated vaccines. And those two things were really connected because integrated vaccines were seen as being the more sustainable way forward, a cheaper way of covering all the 6 diseases or others as well, more cheaply. So in 1998, the polio eradication campaign, which has earlier roots, was given a new lease of life with a campaign to eradicate polio by the year 2000, which wasn't quite achieved. It was more like 2005 or 2006, but obviously that's primarily an immunization campaign as well. And then in 2000, right at the end of 2000, on the 31st of December 2000, Gavi was formed. And Gavi is not a UN organization. It's an alliance of a number of public and private players with a major funding from the Bill and Melinda Gates Foundation alongside bilateral funding. I'm going to come back to Gavi in more detail recently because the foundation of Gavi really marks a departure point for vaccine distribution that has been sustained since the year 2000. So Gavi introduced a number of innovations in the way vaccine distribution and financing was managed. So first of all, it introduced new mechanism to ensure long-term stability and guarantees of financing, which are going to enable markets to function much better with confidence that in 5, 10, 20 years' time, there will be a market for immunizations that companies such as pharmaceutical companies can plan to participate in. The World Bank had pioneered an international finance facility for immunization, which essentially raises bonds on international markets that are based on long-term legally binding commitments of donor countries to fund vaccines. And that enables advanced market commitments to incentivize innovation. So for example, they were able to say 5 billion available to fund it, and that prompted the development of the pneumococcal vaccine that was introduced sometime towards in the early 2000s. They're also able to put all the different demands for vaccines together and exercise much more power in the marketplace. That's mainly via UNICEF, that purchases about 80 or 90% of all the vaccines that are purchased in the world. And that secures lower prices. And those two things combined, incentivizing new players and the new suppliers in the market and organizing demand, has successfully lowered prices. So for the 8 vaccines that are the current major set of vaccines that are offered to children, that price is reduced by 40% between 2011 and 2015. Just going to show you quickly a few slides of some of the trends in vaccination over the period that we're talking about. About 90% of children are reached by vaccination in 2019, but that still leaves 20 million children that are un or under vaccinated. And if you look at those trends, they're broken down by regions for the unvaccinated children. So you can see that they're declining. But you can see that in the 1990s, there was a resurgence and a leveling off of progress in relation to vaccine coverage. And that really explains why Gavi was thought to be needed. It was a failure to raise finance and a failure to improve vaccines and improve distribution mechanisms. And then you can see from this slide that Gavi over time has been introducing new vaccines and plenty of them. So if we started with the 6 that were the basic set in 2000. I talked about 8 being more or less the basic set. Now there are also a whole lot of other vaccines that are variously relevant to different kinds of contexts that have been introduced. And in this slide, I can show you the kind of coverage changes between 2000 and 2019 for this expanding range of vaccines. And from this, you can see that sort of basic set of 6 was essentially reaching about 75% of the population in 2000. And you can also see that basic set of 6 has barely improved from that, now in the low 80%, whereas what the growth in coverage that you can see as you go over these time points is largely that more new vaccines are being delivered rather than reaching the hard to reach for the basic set of vaccines. Okay, so let me turn now to COVID vaccines. Let's start with the development of them. That's obviously a massive success story. Operation Warp Speed was the Trump administration's effort towards developing vaccines for the emerging pandemic, launched in May 2020 with about 10 billion. In the end, it cost over 12 billion. Developed a number of vaccines, the names of which we're all familiar with: Johnson & Johnson, AstraZeneca, or University of Oxford, Moderna, Novavax, and contributed in a different way through advanced purchasing arrangements rather than through funding all the things that it shows in the first bullet, Pfizer, BioNTech. There's also been substantial European investment, especially in Pfizer. But US market prioritization was a condition of the initial funding. So once the 10 billion had been invested in these companies, the condition for receiving that investment was US market prioritization. Generally, other high-income countries have been able to use advanced purchasing mechanisms to ensure they get more than their fair share of the vaccines that haven't gone to the US. And besides that, China has produced large volumes of vaccines, first of all for its own population, and more recently it has been exporting to countries like Indonesia, Cambodia, and most recently been directing vaccines to Africa. And India has also produced its own vaccine. These advanced purchasing agreements that high-income countries have seized the vaccine supply with, you can see in this graph the percentage of each country's population that can be covered with 2 doses based on the advanced purchasing arrangements. And at the top of this, what I call the greedy list, are the UK and Canada that have advanced purchased enough vaccine to fully cover their population 3.5 times over nearly. At the other end of this table, there's a break in this table. There's a long list of countries for which they've obviously put a fairly rough estimate in that they've covered 5% of their populations. I'm sure a lot of them, it's even less than that. Before getting into some of the issues around financial and supply constraints, it's important to recognize that these aren't the only issues. It's not the only reason that it's difficult to get vaccines out to the whole world. There are lots of bottlenecks in processes of allocating, disseminating, approving, and distributing newly approved vaccines. We've seen those in Australia. It was particularly slow to approve and distribute vaccines, and that's why we're so far behind the rest of the world, or the rest of the rich world. But obviously, every country has its own system for approving vaccines and various problems in distributing them. Current global vaccination rates are about 6.7 million doses a day, and that will take us nearly 5 years to cover the whole population, which is clearly no good and creates what the author of this paper that I've referenced at the bottom here describes as an uncoordinated patchwork of immunity around the world, leaving lots of gaps, whether it's because it's vaccine hesitant states in the US or vaccine desperate but undistributed countries in Africa, is going to enable the escape of variants and reduce vaccine efficacy over time. So there are issues there that are not exactly about financial and supply constraints, but about how entitlements to what's available are distributed, which are already clear, I guess, from some of the data that I've been showing you. So the largest initiative to try and improve the distribution of COVID-19 vaccines is the global Kovacs facility. It's not quite the only one. I think the African countries were dissatisfied by the level of priority they were getting through the Kovacs facility. So the African Union and a World Bank African Vaccine Acquisition Task Team developed a program to specifically focus on achieving access for African countries. And of course, as I've already said, the Chinese and the Indian production has first served their own populations, and in China's case, at least exported to other countries now. So what is the Global Kovacs Facility, the largest of these? It's a multilateral initiative led by Gavi. So that the creation of Gavi and the innovations that Gavi has introduced are available for the use of this global Kovacs facility, and that's proving very helpful. It's raised more than $10 billion in legally binding commitments for 4.5 billion doses. So far, though, it's only delivered 240 million doses, and that should reach 139 countries, not 1,139 countries, which is well more than the number of countries that there are in its first 6 months. And it expects to have delivered 2 billion doses distributed by the first quarter of 2022. And there are 92 countries that are participating in Kovacs advanced market commitments. So clearly that's just a proportion of those that are going to benefit through other routes. However, if you take the whole population of the low and middle income world, which is about 6.5 billion, you need 13 billion doses to give everybody two doses. That's about 9 billion if you take the populations of China and India out. Clearly, they have their own supply. So it's still only half, even whenever that 4.5 billion might eventually be delivered, it's only half of what's needed. So here's what Kovacs and WHO are currently asking of the various players in this market to support giving the Kovacs mechanisms more impetus. And this they published just on the 8th of September, so it's very current. First of all, that manufacturers deliver to Kovacs in accordance with firm commitments and provide transparency on timelines to allow countries to plan in advance. Clearly, there are some issues around all that come under that, not really about supply or finance issues. Then they're asking the countries that were on that table that I showed you earlier that have pre-agreed to get 3+ or 2 to 3 times the amount of vaccine they need for their populations, can they give up their place in the queue and make sure that other countries that don't have enough already get better priority? And then the system of donating spare vaccine needs to be essentially better coordinated, and they're asking countries to help with that. So those seem like 3 quite doable and reasonable demands, I think. And then finally, I just want to say a little bit about intellectual property rights issues. These are proving relevant and tricky in the rollout as well, because we're assuming that what the Kovacs mechanism is doing is taking the pharmaceutical industry's prices, accepting its monopolies over its individual products, and not challenging that. But of course, if countries were able to produce any of these tested and tried vaccines themselves, the production could be scaled up substantially and much more quickly. So intellectual property rights allow the pharmaceutical industry to make exclusive decisions about who they're going to sell the vaccines to and at what the price is. They give them exclusive rights to produce vaccines, and there can be no competing generic products. And they decide, as I said, about the prices. And some of the outcomes of that look a little bizarre at face value. So AstraZeneca is sold to South Africa at $5.25 a dose, but to the EU at $2.16 per dose. Now, I think that is probably a bit of an outlying statistic that came from the paper that I quote at the bottom. A lot of the EU investment went into AstraZeneca, so it probably negotiated a low price based on having contributed to that. I should say also that AstraZeneca is much, much cheaper than all the other vaccines that are available that start at about $20 and go to about $100 a dose. So AstraZeneca is by far the most affordable vaccine. Now, India and South Africa have proposed to the World Trade Organization to waive intellectual property rights for vaccines under these exceptional pandemic circumstances. They did that first in October 2020 2020, and they put a revised proposal in this year in May 2021, and that would enable, and I think India and South Africa are the two countries that would most likely start producing the other vaccines. And that proposal has had increasing support, including just this week from Australia finally. However, despite the fact that most countries, including rich countries, are now supporting that waiver, the World Trade Organization rules allow a very small number of countries to block a waiver. So it's not clear whether they'll actually be able to get that proposal over the line. So just some concluding remarks then. The current situation is, as Katz says, short-sighted, ineffective, and deadly. It's a catastrophe for the world. And not finding solutions to this problem is going to be such a huge public bad that it's almost inconceivable that solutions aren't found. The kinds of things that Kovacs and WHO have proposed, as I said before, are reasonable and achievable. Waiving countries' TRIPS obligations is also reasonable and achievable, and it's also fair. After all, these pharmaceutical companies benefited hugely from public and philanthropic investment in the R&D costs. The whole argument for these patents is that the companies should be able to recoup their R&D costs. And they've already, over this first year of the vaccines being rolled out, or nearly the first 9 months, reaped huge profits. So they really shouldn't expect to be able to keep reaping more over the normal life of the vaccine patents. However, despite these all being reasonable and achievable, I don't think we can assume that anything other than the continued slow rollout through Kovacs and other initiatives will actually take place. So thank you very much.
Okay, there was quite a bit of information there to process. Would any of the panelists like to reflect on what was spoken?
Dr. Tori, I think you're on mute.
Sorry, everyone. I was trying to be quiet while the presentation was on. Yeah, I just wanted to say I found it a really interesting and holistic look at the issue. I found it very interesting to see that the evolution of Gavi as this global purchasing power, that we're able to then harness that with the Kovacs facility. But yeah, I mean, as Barbara points out, there's still gaps and there's still a long way to go, and those recommendations or those asks from Kovacs, I think, really should be met in order for us to get better equity of access to vaccines.
Someone has their alarm on.
I don't think it's me.
Yep. Yeah, so there's definitely the whole sort of business element and economics element to the purchase, supply, and manufacture of vaccines. Is there anything you'd like to share, Baneen, before we get into the questions?
Yeah, I'd just like to echo what Dr. Tori said. I think it was overall a very holistic presentation, and also it filled in a lot of those gaps and just highlighted where the gaps are and what we know and what we don't know, and just the importance of, I guess, just being open-minded and taking it all one step at a time.
Excellent. So we have some questions that come through from the viewers. The first question is for you, Baneen. In the context of the coronavirus pandemic, how do social determinants of health play a part in making the decision to take the jab?
Yeah, sure thing. So I think when we look at social determinants of health and taking the jab, it's probably mainly how it impacts vaccine hesitancy. And when we talk about vaccine hesitancy, we're just talking about the delay in acceptance or the refusal of taking the vaccine despite its availability and the accessibility to the services. And when we look at some of the things that may factor into this, you can break it down. And so you can look at things like confidence. And when we think about confidence, we're talking about trust. So do people trust the effectiveness and the safety of the vaccine? Do people trust the system that delivers them? And do they trust the health professionals as well? And also, do they trust the motivations of policymakers and people who decide, when we need to take the vaccine and which vaccine we need to take? And when we look at our culturally and linguistically diverse communities, we notice that there's a lot of misinformation. So for example, I know my parents use WhatsApp a lot, and there's a lot of misinformation on WhatsApp. There's also a lot of mixed messaging, and this mixed messaging is also coming from our government. And like, I've been born and raised in Australia, so my English is quite good, and I sometimes find it confusing with all of the mixed messaging and the different public health advice and the constant changes. And you can only imagine how much harder that would be for people who have linguistic barriers. So if you're not somebody who speaks English, and then there's also poor like institutional trust. So a lot of people from culturally and linguistically diverse backgrounds have come from countries where there is that lack of trust with, I guess, the institution, and you don't really trust what they tell you to do. So when they come to Australia, that lack of trust might still be there. There's also the perceptions of pharmaceutical companies. I know I've heard a lot of people from my community talk about, like the fact that they're giving us this vaccine because it's more money for them. And there's all that like lack of trust with our pharmaceutical companies. And also just because when we think about trust and confidence, anecdotes have such, like, they're so powerful and they're so strong, and you can see the social media using anecdotes and using these sensationalist emotional stories, and it's really swaying people's perceptions of whether they should or should not take the vaccine. Another thing to consider when it comes to social determinants of health is complacency. And when we're talking about complacency, we're talking about, like, sometimes some people may perceive the risks of COVID-19 as low, especially in Australia. And so because they think there's a low risk of getting COVID-19, or even when you do get it, they don't believe that the side effects are that bad, so they don't take the vaccine. And again, when we're thinking about how this impacts our communities, we're talking about things like the social norms, the conversations that are happening in our communities, also religious affiliations and philosophical and cultural beliefs. So you'll hear people saying things like, because they're religious, they'll be like, I don't need to take the vaccine because, God is here and he'll make sure that I'm okay. But the thing is, at the end of the day, you still need to take that vaccine because there is scientific evidence. And even though you are religious and you believe that there is a God, it's still important for you to follow that public health advice. And then another thing to also consider is convenience. And we've already talked about that a bit, but like the physical availability of the vaccine, the geographical accessibility of the vaccine. And I think for our communities, one of the most important things when it comes to convenience is that linguistic barrier. Is the information about the vaccine being communicated in multiple languages, both in written and verbal format? And not only is it available, but like, do people have access to this? And yeah, there's, like, as you can imagine, there's so many other factors that also play a role, but these are some of the more important ones. And it's just, at the end of the day, when it comes to social determinants of health and when it comes to vaccines, it's just really important for us to have this very community-centered and patient-centered approach, which I guess the government the government still hasn't fully achieved so far.
Thank you for that response. So many determinants there. We have another question from our viewers to Dr. Tori. Isn't it in the best interest of all countries to have everyone around the world vaccinated? Otherwise, wouldn't the virus end up mutating?
Yeah, absolutely. It is certainly in all of our best interest to have equitable access to vaccines. In part for the reason you mentioned, as long as the virus is raging anywhere in the world, it can continue to spread and it can continue to mutate, likely or possibly into forms of the virus that is resistant to the current vaccines that we all have. So it's in everyone's best interest that we all can be protected from the virus, and it's not just a health issue. There has been estimates that from an economic standpoint, we've tried to quantify the cost associated with having this inequitable access to vaccines, and it's in the region of trillions of dollars per year that it's costing not just those who don't have access, but all of our global community. So I guess, Dr. Tedros, the Director General of WHO, really summed it up well when he spoke about that economically, epidemiologically, and also morally, it's in all of our best interest to make these vaccines available to all. It absolutely is, but I guess it's a much more complex decision facing policymakers who sort of tend to act and think within the confines of what's best for the people within their national borders, which I guess that nationalistic thinking is something that's only really worsened with the onset and the progression of this pandemic, which is it's ironic and it's unfortunate because like nothing else, this pandemic has shown us that we are in this global community together, and it should reinforce that global solidarity rather than nationalism is the way forward for all of us. But I think it's a long and complex road to get to that recognition from within those policymakers that are thinking nationally.
Yes, correct. And I believe the Prime Minister is on the record of saying COVID knows no borders. So,
absolutely,
as you correctly pointed out, what happens in Africa does affect us in terms of the global pandemic. A question for Baneen. What can the public health system do to engage communities which are somewhat detached from the public health system, given their social situation?
Yeah. So as I touched on this a bit in the last question, but I think one of the most important things here is focusing on this community-led and community-centered approach to care and approach to, I guess, spreading vaccine awareness and preventing or reducing vaccine hesitancy. And so when it comes to this, some things that we have to consider is how can we engage community leaders? So with our culturally and linguistically diverse communities, we usually have a couple of community leaders. And how can we talk to them and how can we engage them? Because these are people that our community members trust. So if we're able to tap into them, if we're able to educate them, and if we're able to get them to be the ones who disseminate that message, that might overcome some of the barriers that we're currently experiencing. Another thing as well is that addressing that linguistic barrier, and I've talked about that before, but I think, like, I know I bring this up a lot because I know it's something that's affecting my family, because I know both my parents' English isn't great, and when it comes to even when they wanted to get the vaccine, they didn't really understand what it was and how to get it, and like all this information that you'd expect to be readily accessible was not accessible for them. But the good thing was that they had me and I was able to communicate that to them. But I know for many people that's not the case. So how can we make sure that we have this information ready? And not it can't just be ready. It has to be information that our community is actually using and accessing. So it needs to be there. But like, how can we also disseminate it? And how can we make sure that it's culturally appropriate? And the only way to do that, or from my perspective, maybe not the only, but the best way to do this is to actually involve the community. So we need community members to be assisting us with putting together this information and disseminating this information. And I guess something else maybe is just as I talked about before, like we have WhatsApp, and that's used a lot in our communities. And I bring that in because I think it's important for us to also understand that a lot of people from culturally and linguistically diverse communities may not be using the same media outlets that other people use. So they may not be watching the ABC News. They may not be reading the local newspapers. So we need to understand where they're getting their information from, where they're getting just their local news from, and tapping into that and providing resources through that. So if it is WhatsApp or if it is a specific platform, we need to make sure that we're aware of them. And like, I guess the public health system needs to be aware of that, and then we need to tap into those and disseminate information through that. And I think that's all I have. I don't know if Dr. Tori has any other ideas.
Oh no, I just wanted to say you talk about this incredibly complex issue of what dictates people's decisions to get the vaccine so well, and I found it really compelling when we spoke about trust being such a big factor in those decisions, and that's something that is not easy to address. You can't just instantly build trust once the vaccine is here and you want people to take it. And so I think you need to recognize that those things take time, and engaging the communities in those decisions and engaging the community leaders is so fundamental to building that trust and providing that information in a format and a place that can be trusted and can be acted upon.
Yeah, no, 100%. And I think it's also just about creating that environment where people feel comfortable like asking the questions, and they don't feel like we're going to judge them or that they're going to be talked down upon. Because at the end of the day, if there are questions, it's because they're concerned about their health, and it's our role to address those concerns and not just mock them. And when you're able to create that safe space for those conversations, I think that's what we need. And once we're able to get that, we
Yeah,
can
it should
overcome a lot of those barriers.
definitely. It should be a discussion, not a one-way directive. 100%.
On that topic, so yeah, of course, building trust takes time, but at the same time, you know, we've had some policy where, you know, it's sort of been enforced on the population to reach a certain rate, so you know we have less of the spread of the virus. And I think there's been probably a portion of the population being triggered because they feel like their rights have been entrenched on. What are your thoughts about that?
Baneen, you please go first.
This is a very it's a very hard question, I think. So I guess it's hard here because with the vaccine, so there's this concept of herd immunity. So the more people who are vaccinated, the safer the general population is. So if you don't get vaccinated, you're not only affecting yourself, but you're affecting the local community and everybody around you. And I guess that's why, from my understanding, that may be why the government is enforcing these rules. I think there's a middle ground that needs to be met where we are encouraging people to get the vaccine. And I think encouraging people through incentives. So for example, like the vaccine passport, where if you have the vaccine, you're able to do more. But I think ultimately we do need that freedom. And I think if we're able to give people that freedom to make that choice, what it does is it puts pressure on, I guess, the healthcare system and policy and all that to educate people more and to make sure that they're providing those resources so that people aren't taking the vaccine if they don't feel comfortable. Right now, what they've done is by enforcing it, it takes away from, it takes away from them having to make sure that they're communicating everything effectively. So overall, it's probably, it's hard because of the concept of herd immunity. But I think at the end of the day, we shouldn't be forcing people to do something that they don't feel comfortable doing. But we should be working on educating people so that they're making that decision and they're making that right decision for them and for the rest of the community. But yeah.
Thank you. Any comments you'd like to make, Dr. Tori, before I go to the next question?
Oh, no, I mean, I think, Baneen, you summed it up really well. I think it's, you know, if that can be made through the decision to vaccinate can be made through an informed choice of the individual, that's always preferable to imposed or mandatory vaccinations.
Excellent. Yeah, we have a question for you, Dr. Tori. Do you consider booster shots to contribute to the problem of vaccine inequity? Is it a better policy option to distribute the additional vaccines to developing countries?
Yeah, it's another really complex question, actually, and I guess it sort of speaks to what we've already discussed before, in the sense that yes, it for our global protection and our global well-being, it is a better policy option to forego those booster doses until, you know, the rest of the world can also achieve that high coverage of vaccination. I guess the trouble is the same behaviors and the same principles that were underlying that initial race for the initial doses of the vaccine are coming back into play when countries are making these decisions around booster doses. So unfortunately, we don't seem to have learned or have moved on from those issues. And as I said before, you know, political leaders are making those decisions with their own national populations in mind, and it can be very hard to change those, change the incentives that lead to those decisions. But I think it's something that pressure from international bodies and even pressure from the communities. I think the more that the local community stands up and recognizes that we're all in this together, and it's not just about having our nation vaccinated and then boosted. It's about, you know, we're all in this global community together. I think that message really needs to be coming in strong from all sides, so that policymakers are making decisions with the global community in mind rather than just their national borders.
Yep. Thank you for that. We have a question. I think there's no one that's specifically asked you, so I ask, you know, of the panelists to feel free to answer this. From a community perspective, do you have any suggestions on what community members can do to help our communities communicate public health advice?
Dr. Tori, did you want to answer? I'm
Yeah,
happy
I mean, I'll talk very, very briefly. I think it really speaks to what you've already spoken about today, Baneen, and that's that recognizing that messaging about health comes from many different sources, and it's not only up to the traditional public health institutions to spread that information and spread that awareness about the benefits of vaccine and the importance of these public health measures. I think we all have a part to play in spreading that awareness and that information within our communities, and recognizing that it's our responsibility to inform ourselves and spread that information to our peers, because sometimes that's going to be the most trusted source of information, and that's the type of information that's going to have the most impact. And I guess just emphasizing that beginning with the correct information yourself is really the best way to go about that, and make sure that you're reading reliable information and you're informing yourself with the I guess the correct information that you can then go and spread to your community. Baneen, I'm sure you've got more to add to that.
Something else, like something I would add as well, is if you don't have that information, like it's always like you can always just tell them to go see a GP. So if you don't feel comfortable giving them that information, tell them to go see a health professional, and then they can have that conversation with their GP. That way, you don't feel that responsibility of having to know everything and having to know all the correct information. But at the end of the day, it's also just about like not being judgmental. Like vaccine hesitancy is understandable, and don't ever mock anybody. Try to create that healthy safe space, as I was talking about before, and just having those discussions. And also, like, don't be afraid to reach out. Like if you notice that somebody is a bit hesitant, don't be afraid to talk to them about it. I've seen a couple of my friends, for example, putting like posts on their Facebook and just saying that they're more than happy to have a chat to anybody who wants to talk about why we should get the vaccine or how the vaccine works. So even just these really small things can really make a big difference. And even just like something like this webinar, and if you are part of a local community, organizing a place where, or an event where you can just sit and talk and explain things to people and answer their concerns. I know that there's currently in Shepparton, so Shepparton's an hour away from where I lived, there's a grassroots organization called Wise Well Women, and they're just creating small sessions where they sit and they answer all the women's questions, and they talk about what it means, what is COVID-19, what it means to get the vaccine, and that's helping a lot of people feel a lot more comfortable with getting the vaccine. But yeah, other than that, I'm not too sure.
I think you guys have raised some very important points. Credible sources, and I think a lot of this information is shared on social media, and that's where a lot of people are getting the information naturally, because it's not everyone's sort of forte to be researching all this or have the time to. You guys are the experts and are doing the research for us. We only try to get this synthesized version of that information. I think we're running out of time. Final thoughts from both panelists before we end it?
I just want to say I think it's been an incredibly interesting and fascinating discussion today. I've really enjoyed looking at this issue of vaccine equity from many angles, and looking at I guess the complex milieu that really influences how people can access and are accessing vaccines. I think the more that we acknowledge it's a really complex issue, the better that we're able to address some of those barriers.
Yeah, and I would also agree with that too, and just about like that balance between the physical availability of the vaccine and also like the accessibility of the vaccine. And it's been very interesting as well, just reading all of the comments that are coming through in the chat, and just kind of having a better understanding of the people's ideas and their current thoughts about the vaccine and COVID-19 as well.
Yeah, I feel like it's something that we could talk all night about if we wanted to address all the comments. I don't know if you wanted to, we could maybe address them offline, send out a follow-up Word doc. I don't know, but yeah, it's been a really great discussion, comments included.
Yeah, perhaps the team could provide some sort of contact for those who'd like to ask you guys questions, and they can address the questions to yourselves. Well, I think that brings us to the end of the panel and the Q&A. On behalf of the Advocates for Dignity, I'd like to thank you, Dr. Tori and Baneen, for very insightful discussions around the inequity of vaccine distribution. It's a very important topic and has become so relevant to many people's lives globally. I'd like to warmly also thank our viewers for tuning in tonight and listening to the panel discussion so patiently. Thank you for your valuable contributions and excellent questions, which kept us on our toes. Please do not forget to fill out the feedback form available. I don't think we have it on our YouTube chat, do we? But there definitely will be a QR code that will come up on the screen. You can scan it and the feedback form will come up. Or if it's on the YouTube chat box, you can access it there. And we'd love to hear your feedback. Have a great rest of your evening and stay safe, everyone.
Thank you.
Thanks, guys.